some components. You don't want them to move when the surgeon makes the incision, so immobile. You don't want them to be in any distress, and I think movement would do that. You don't want them to remember the experience, and you also want to try to control pain. All these things go together. Many times you'll hear people talk about how flying a plane, flying a plane and anesthesia are very much the same. So what's the first part of the plane? Let's say you're already on, you're getting ready to, they close the door, what's going to happen? They've done the safety checks, the pilot's in there going, you know, check, 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 okay? The stewardess has done their safety shield, that's awesome. They're gonna call the tower, and the tower's gonna go, okay, we're ready to go. So that is what? What are we gonna do? We're gonna take off. So when you're flying the plane, you're the pilot, you're gonna take off. What part would that be for anesthesia? Induction. Okay, we're gonna take off, right? We're gonna go to the new world of general anesthesia. Right, so we get up there, we got the plane up there, we're gonna be cruising, what's that? Okay, so that's maintenance in anesthesia, right? All right. And then, oh boy, then we're gonna get to our destination in the plane, and what are we gonna do? Emergence. We're gonna land the plane, and we're gonna be in emergence. So those are the, I would say, 3 basic components, and there's before and after kinds of things you do. But you should know those. And what would be the most dangerous points you would think in anesthesia?
Induction and emergence.
And what about flying? Okay. So you're going to be vigilant the entire time this patient is in your care. Induction, pre-induction, preparation, maintenance. That's when you see the ABCs of anesthesia, airway book computer. And then on emergence or landing, that's another time that can be super, super dangerous. So, and now don't get me wrong, in maintenance, if you're not watching the vital signs, you're not keeping them in that hemodynamic balance, that's trouble too. Someone could have an issue related to either when you gave succinylcholine or when you turned on the volatile anesthetic agent. It may not happen right away, it may happen over time. What would that be? MH, hyperthermia. So if they had a reaction to succinylcholine, or if they had a reaction or gas triggered this big event, a lot of times that happens, it can happen during maintenance. Okay, you're just like, what's wrong? The end title's going up, what's wrong? They're breathing spontaneously, like stuff rapidly, what's wrong? Something's not right. So you start trying to troubleshoot, are they in pain? You know, they might be in pain. Okay, well, if they're in pain, then I can give some narcotic. This end title, there's something not right. Something's not right. So you change your vent settings to try to get more breaths or bigger tidal volumes to get the end tidal CO2 down. And something's not right. Something's not right. I just think something's not right. So you call your supervisor and go, listen, I've done this, but something's not quite right. I'm thinking, I had the thought, I wonder if this is MH. I wonder. And then you start, you know, troubleshooting and differential diagnosis. You look at all the possibilities of what it could be, and you rule those out, and you go to the surgeon, this is a possible MH thing. And if it is, get help, get it fast, because you're going to need a bunch of people to do that. Yes, indeed. All right, so we're going to talk about these components. So this would be induction, maintenance, emergence. But first you got to get prepared. Now, I don't know what you're going to do in your sRNA practice, but when I started, I got there real early. First cases, I think we got out there 7:15 at the time. I got there usually about 5:30. And the time, I didn't have to get there quite so early as time went on, but initially, no one could say I wasn't trying and that I wasn't there early to do my very best to get stuff done. But they could say that I didn't do it well. You know, they could say that. They couldn't say it wasn't because I wasn't there on time and I wasn't trying, all right? So these are the basic components. Preparing, and you had a chance, those of you who went yesterday and those of you who are going tonight, you have a chance to see what that prep is. Machine check, drug setup, I'm not sure what else Dr. Pavlov, is he having you do stretchers and learn how to work those, or all kinds of stuff? What's he having you guys do? And then, you know, in this class, did you see the little anesthesia gas machine handout that I gave you? It's something that I prepared for public documents. That might be a helpful guide for that. After we prepare, then we're going to pre-induce. So what does that mean to you? pre-induced, pre-induction.
So this
Okay,
is,
so we might deal with the issue of I'm going to have surgery, the patient is thinking, and they might be anxious. So what would we do to help with pre-induction maybe? Does every single person get percent? Sometimes I just, especially older folks, I ask, do you feel anxious? Would you like something to help you relax? And someone will go, yes, because I didn't drink my wine this morning when I woke up. Okay. That's something I can relate to. So yeah, Versed, we want to help relax them. And also part of pre-induction would be, hi, my name's Dave Ron. I'm going to be your nurse anesthetist today. I'm going to be taking care of you 100% of the time. And also on the team is Dr. So-and-so, and they're going to be, we're going to work together to take care of you. I have to say it in an appropriate way. I do not want to give the impression that I'm not the one that's there 100% of the time watching every breath and every heartbeat to help that person get through that safely. But I also, because of where I've chosen to work, want to give the impression that this is a team thing. So in a 1 hour case, my physician probably takes care or sees the patient maybe a total of 5 minutes, maybe, and I'm there the rest of the time. I like that. Gives me some control. For induction, what are we going to give? We might give etomidate, but that's probably not too often. We're probably going to give propofol. When would we give etomidate? When we're worried about what?
Blood pressure. Aspiration.
I'm always worried about blood pressure. Aspiration? Maybe, but there's a better answer.
Sepsis?
Maybe, because what goes along with sepsis?
Arterial deficiency?
Okay, maybe.
Or if they have a history of pseudophone and aspiration deficiency.
Maybe.
Yeah,
That's twisted. But maybe. No. Awareness?
you
No.
give etomidate
So-
RSI.
Sometimes,
Yeah.
yes. Sometimes. So those are good ideas, but I'm thinking, what comorbidity, let me change the question. What comorbidity would be something, besides like if it's a trauma, maybe level 1 trauma, and you're thinking rapid sequence, I think etomidate might be a good choice. Sure. What comorbidity, one single comorbidity do you think we'd be concerned about that etomidate might be a better choice over propofol? Yeah.
Is it a neurological disorder?
Maybe.
OSA.
No, no, maybe, no.
Diabetes or delayed gestational.
No, but those,
Myasthenia gravis.
no, you're thinking. Okay, let's, I'm going back to basics. Because you guys are like way up here and I'm trying to get us down here. So you're way ahead of me. Yes.
Just throwing it out there, maybe an egg allergy. Like I know that has a
Right, it's
Well,
fat soluble.
I would say that might be a consideration, but no. So I think it's worthwhile to say, but, All right, so as an anesthesia provider, people can have a million things right with them, and we love those patients. And they can also, and I say right and wrong with them, we're talking about comorbidities and things health issues they come to us with that we have to deal with and then change our anesthetic plan because of that. So using etomidate would be one of the anesthetic plan changes we might make if they had one of these conditions that I'm thinking of. So what would be the two main, of all the body systems, there would be two main ones that we are most worried about.
Respiratory.
Cardiac and
Respiratory.
Okay. Of those two, etomidate is better for one than the other. Do you know what? Cardiac. Okay, so now I asked the right question. So etomidate would be a choice usually when someone has heart issues because it's easier on the heart. Now, everything else you said could be a factor and a reason, okay? I have probably not used etomidate in maybe, well, I'll say it this way, I may use it once or twice a year out of 1,000 cases, maybe. Now, that's not to say that my people aren't sick, but I will say a lot of them are not as sick as you will see at some of your clinical sites, because I'm not a level 1 trauma place, and I am not a place, politically correct way to say this. I work at a place where people generally pay their bills. We do, because we are a religious associated hospital, we do take quite a few of the poor, regardless of their ability to pay, that kind of thing. But some of the other places in town, or other clinical sites you go to, don't have those parameters much. We're a private place, okay? And they choose to take care of many people that aren't able to pay. So I don't want to talk bad about my institution that I practice at, but it will be different than some of the other clinical sites. So we would use etomidate when the person has what? Major comorbidity? Okay, I like that answer, that's good. Now, most of the people I just give propofol to. Now when I give propofol, what can happen? In terms of how might the patient respond, they will eventually go to sleep, but how might they respond? Is there something about propofol besides egg allergy, which is a possibility? A lot of times it burns. And if they only have a 22 gauge IV in there, like a small one, it's more likely to burn. And if it's in a, like in their hand as opposed to in a big blood vessel like in the AC or in their forearm, they're probably going to notice it. Some people are real sensitive to it and they almost jump off the table and you're like, wow. And then other people just generally go to sleep and don't even act like anything's going on. But if it's a smaller IV, I expect it. And depending on where it is, it's more likely for them to cause discomfort. And then just how the people are made inside chemically, which is way beyond my pay grade. I don't understand that stuff. Well, I guess a little bit. So what might we give before we induce with propofol?
Lidocaine.
So lidocaine will help numb that blood vessel. If you give it too soon, though, it'll be long gone before you give the propofol. So you need to be ready. You know, gotta have that stuff ready. So induction. All right. So drug-wise, we're just getting the room prepped. So we've got all our drugs ready. That includes what we're planning to give for induction, maintenance, pain control, nausea and vomiting considerations. We got the whole room ready. The machine's ready. Pre-induction, we're probably going to. The first drug will be meeting them and helping them feel safe and comfortable and build trust with you. So that's what I'm paid on. I'm an O'Connor. I'm a nurse anesthetist. I'm going to be taking care of you. I'm going to watch every breath and heartbeat consulting you through this. That's where I first build trust. So that's kind of like my drug factor to help ease their anxiety. Then I give them the real deal. Okay, here's some Versed. Now you don't care, and now you won't remember how wonderful I'm going to be to you. That's okay too. So that's pre. And then induction, maybe a little lidocaine, a little propofol. They drift off to sleep. How do I know for sure they're asleep? This comes from the slides too. There's a response that they lose.
Eye reflex.
Okay, so the eye reflex, how do you do that?
With your finger
Yeah, just gently on the lash. And if they go, then you're like, okay, well, they're not deep enough yet. And if they stop all that, then you know they're probably ready to go to sleep. So now we've got the patient asleep. We're inducing. What might we give so that we can then go to our intubation portion? A muscle relaxant. So it could be succinylcholine. It could be rocuronium. It could be
pancuronium.
It could be pancuronium, but unlikely. Now, some places still have it, and some places would use it for hearts because it's a real long-lasting, so long-lasting. I don't recommend you guys doing that at first because you don't want to burn a bridge if you can't go back over that river. If you know what I mean by that, here's what I mean by that. If you give a long-acting muscle relaxant to someone, this is me pushing the drug, I do just quite with that. That's smooth move is. So I give it, and that drug's gonna last hour and a half. And let's say you can't intubate, and you cannot ventilate that patient. You can't ventilate, you can't intubate, now what? Because you chose this long-ass Oh boy. Yeah, really. Okay. You made a decision to give that long acting is what I meant to say. Muscle relaxant. I'm glad my spouse didn't do that when I would never move down. Wow. You may have been the person that made the wrong decision for that person, and maybe they can't be saved because of what you did. Now, succinylcholine, how long is it last? Any ideas yet?
Shorter.
7-10 minutes, maybe 15. Okay. So that one is not a big bridge because most people will have their oxygen still in there and it's still circulating and it can last. Brain death doesn't happen till what 7-10 minutes. All right. So isn't that convenient that succinylcholine's like right there? That's a good thing. So when we get ready to induce, we've given a little lidocaine to help decrease the pain of the propofol that we're going to give. We've already given that. And then we're going to give probably, in some places you go, they say, no, we don't use succinylcholine. Some of the places you go, they will not use it. Okay, because it has some bad things to learn about. So they may use rock or they may use vecuronium. Those would be the two more than pancuronium. But that is another option, but we don't use it much at all in my normal everyday practice. Because it's so long acting, I don't want to burn bridge. So if you go to a place that uses succinylcholine, you might give a little sux, and I like it because it's short acting. Even if I can't intubate, can't ventilate, I know it's not because of the drug. The drug's already worn off. Okay? Which then we're going down this difficult airway algorithm. We already have the difficult airway card in there. Got a ton of people in there to help try to get to secure the airway. But it's not because of the drug that they're not breathing. So I give some sux, and what does the succinylcholine do to your cords? It takes them, so these are the cords right here, and they're kind of nicely colored white. God did that so you could see them. So then succinylcholine gets to the receptor sites, and guess what happens? And then when that happens, guess what happens? You take the endotracheal tube and you put it right through there, and you watch the cuff go through, and then you inflate the cuff. Now you have secure airway. Yay, you got there. Now sometimes people will give just rock, and usually it's a lower dose of rocuronium. It lasts anywhere from 30, 45 minutes, and you will learn specifically what you should know for that answer when you either work with Dr. Shore or Dr. Self. They'll tell you what number you need to know. But I'm just talking about my normal experience. So it's relatively short acting, and then VEC would be the next one, because VEC and ROC are intermediate acting ones, but ROC would be the one, if we can't use sux, it would be the next quickest to wear off.
Did you say that one more time?
Short off. So I think this is what you mean. It's just because I can't remember. No, so we have short-acting muscle relaxants and free sux. We have intermediate ones, which would be rock and VEC, and then we have long-acting, which would be pancuronium. Okay, and in the order of how they wear off, typically, this is again from clinical experiences, but you will learn actual numbers. Sux wears off first, then rock, then VEC. Is that what you need?
Yes.
Okay. I remember it this time. Yes.
What about on your sheet, the cart options for midvecurium?
Okay, so have you learned about midvecurium? Don't worry about it for now. But if people have kidney problems, that might be one that you would use. And rarely do, yeah. We use it some, but
And same
that's,
with cis.
yes. Those, you will learn about those, but for the purposes of this lecture, you can just know that they are other muscle relaxants that exist. And right now we don't have to break out. So we'll just keep it basic. But the example I gave you is from, I think it's from Mount Sinai Medical Center from Miami. And it's just to give you something to see how people prepare, okay? But again, just like every institution has different protocols and policies, this will be the same kind of thing. They'll kind of tell you, your peers above you in the class, they have you say, well, this is how we do it. This is how I do it. This is what the expectation is at this clinical site, and they'll help get you squared away first. But I wanted to have something to look at so you have an idea of how you prepare.
Doesn't propofol come in 10 milligrams per ml?
Yeah.
Okay. It says 20 on here, so that should be, that's an error. Is there different concentrations?
What was she looking
I would say, now apparently, unless it was an error from Mount Sinai, all the ones I've used are 10 milligrams per ml.
Okay.
But there might be one, but that's not, I don't
Okay.
use it. So I wouldn't get caught up on that detail.
Okay,
But generally speaking, it's going to be 10 milligrams per ml. That's what I would learn.
that's what
So keep the good, dump the rest.
Okay.
So, all right. But those are good questions. All right. We've got the patient asleep. We've got a tube in. Now, what are we going to do to keep them asleep for our maintenance? Inhaled anesthetic. That sounds like a really good option. Here's what happens when you guys are new. So I'm telling you now, so maybe you'll put it on your checklist, at least your mental checklist. So we've given Versed, we've introduced the patient, we've got the room already. We've given a little lidocaine to reduce the pain of the propofol. We've given the propofol, the person just asleep. We do our little lid reflex. We know they're asleep. We give a little sux or rock or VEC, and we give the dose again. How am I supposed to? So that's what that means. It's so cool. We give it. They're asleep. The cords are open. We put the tube in place. We put the cuff up. We hook them up to the monitor, and hook them up to the anesthesia gas machine, and then what?
Turn on.
Do not forget to turn on the gas. So, you're so busy with all the details, and there's a million details when you're starting out. That's why routine and checklists are going to be your friend, and that's why we associate this with flying a plane, because that's what keeps you safe there. They have all these routines and checklists. Same thing with anesthesia. Some people forget to turn on that gas. So guess what's going to happen in, 5-10 minutes while you're charting diligently and all the good things you're going to do. You're watching to see the IVs dripping, and you're watching their hemodynamic status, and all of a sudden they're like, heart rate goes up, blood pressure goes up. They're waking up because you didn't turn the gas on. I like that emphasis. Don't forget to turn the gas on. Please, don't forget. There's a little button, you push it, and then you turn the dial. If you get caught up in the details, you'll remember if you didn't turn the gas on. The patient will remind you that you did not. So make sure that's one of those top things. Everything's important, so you don't want to miss anything on the checklist. But keeping them asleep has got to be one of those top priorities. All right? So a lot of people forget that initially. So what we're doing here for the maintenance is what we're doing is exactly that. We're maintaining their hemodynamic status. So when we maintain their hemodynamic status, that means we're watching heart rate to keep it within a viable, life-giving range. Not too high, not too low. We're watching blood pressure. Not too high, not too low. We're ventilating if we're on general anesthesia. They could be under general anesthesia and they might be breathing spontaneously. We do that for certain kinds of cases too. But not if you gave them rocuron or Vecuronium. They're going to need your assistance. So you're going to have to put them on the ventilator. Don't forget to turn the vent on. A lot of them have just a little, you have everything ready, you've got it all set up, how many respirations you want, what the tidal volumes are, you've got the gas turned on, you remembered that part, but now you didn't turn, you got to flip that switch. Now the ventilator's on, the bellows goes up and down, air goes in, air goes out. That's another important thing you don't want to forget. And a lot of times, that is one of the things I noticed when I work with newbies. Forget the gas, they forget to, okay. Because you think you did, because you got all the settings ready, but you didn't go on or off. Please don't forget that part. So that's really what we're doing in maintenance. We're making sure everything is balanced. And then emergence, we're going to turn the gas off. We've already been probably getting incremental, doses of narcotic during the case. And how do I know if the patient needs narcotic? Heart rate usually goes up. And so if they're breathing spontaneously, it's great. Because if they start breathing fast, you can just work in a little bit of fentanyl, for example, or a little Dilaudid or whatever, and morphine. And you can just see the respiratory, like, now I'm more comfortable. Thank you very much. Another thing you probably will do at the beginning, you might give a little Decadron. Why would we give Decadron? There might be a couple reasons why. PONV, post-operative nausea and vomiting. We might want to reduce inflation. Yeah, I'm thinking I looked at that stuff this morning. Inflammation of the airway, you might want to, or just in general, so you might want to give a little Decadron up front. You do not want to give it to an awake patient. You know why?
I learned the hard way.
Okay.
People.
Oh, what does it do to people?
It's their genitals burn.
Their perineal area, that's the word we can use. Okay.
Good.
I have learned this because, again, I would blush again if I use whatever language. So, yeah, it makes them get hot, like a hot flash. Like this hot, burning, like a...
Why?
The lady I gave it to thought I was trying to kill her.
It's like it's the question why, a quick answer would be like a histamine type response. So I'll let you finish the rest of the why, but that might make you happy for now. Only tell the kids what they need to know, right? They ask you a question about, where do babies come from? You go, well, mommy and daddies that love each other, blah, 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 whatever. So, kind of like a histamine response, right? That's good. What else do I want to tell you about that? At the end, when we're waking up, another thing for PONV, we might give another drug, which is Zofran. And typically, I think the literature says 30 minutes near the end of the case. Now, Dr. McDonough may have another case, unless he's changed his mind based on newer evidence that's come out. But he likes to give it up front, the Zofran. And he is blocking those receptors early on. Also, if you get it up front, they can redose it sooner. But you don't want to give Decadron when they're awake. And then if you feel like you need to, just tell the patient. And you give it diluted and you give it slow. and it's not as bad, but they still may get that rushy, hot thing that you want to make sure you've at least told them about it before you do it, because otherwise they'll be telling you something right away. That's how I learned about how to use Finnegan. Back when I was first nursing, I gave a patient some Demerol because they were in pain, and then they were super sick. Now, they weren't sick before. I'm the one that made that person sick. Now, had I had a little bit more insight or experience as a nurse, I would have gone, I would love to give you some pain medicine. And I would go, I'm also going to give you some medicine to help prevent you from being nauseous. So I'm going to give you this first, and I'm going to give you this. And hopefully they'll be good. So that's one good way to learn, isn't it? That's awesome. Okay, so another thing in emergence, we want to get them breathing spontaneously on their own. We can work in any extra narcotic we need. We've already given the antiemetics. We turned off the gas. We're going to turn up the flows of oxygen because we're going to try to get rid of that gas. And they start waking up. Okay. What stage, you learned about the stages of anesthesia in your reading, what stage do we want to avoid pulling that tube out?
2.
2. Excited delirium stage. Because they're more likely to have what? A laryngospasm. And I'm sure that you are experts in dealing with laryngospasms, but why be the one to induce it? So if they're in stage 1, they're awake, and they're almost like grabbing the tube. You know that from ICU days. You know, you turn off the fentanyl Versed drips or the propofol drips or whatever, and then they start waking up, and then they're like, if they're trying to pull the tube out, then they're probably ready to have it come out, all right? And for you guys, those experiences when you extubate people might be a little dramatic at first. I like it when it's peaceful and quiet and there's not much coughing and stuff. But it will come in time. Stage 3, you can extubate people if they're deep still, but they don't have a protected airway. Sounds scary. And I would not expect that in your first probably year or so would you be doing deep extubations, but I do want you to know they exist, but they're not safe in that they don't have a protected airway, so if they aspirate, it's on you. But it's really smooth and really nice, and they're still a little sleepy, they're breathing spontaneously, they have good tidal volumes, they're not at risk for aspiration in terms of their comorbidities or the procedure that they had. And you just pull that tube out, and you suction first, and pull the tube out, and taking your PACU, you might have to put an oral airway or nasal trumpet to support their airway. And by the time you finish with report and PACU, they're like, waking up is so nice. So the deep extubations will probably not happen for a long time, but just know they exist. Then when they get to PACU, what are your responsibilities? You're going to give reports, you're going to transfer care to that patient, you're going to get their vital signs. You've already written PACU orders, either in computer or paper, however they do it, so you're at. So you're going to write orders for blood pressure, you're probably going to, which would include like a bolus of fluid. You're going to have either labetalol, hydrolazine, you're going to write just in case PRN orders the PACU nurses need it. You're going to write something for pain, you're going to write something as an antiemetic. If they're a diabetic, they're going to get their blood sugar checked again. If it's someone that had EKG changes in the case, but otherwise they were hemodynamically stable and they went back to normal, you might get a stat EKG. If it's someone you felt like you had respiratory issues, you did some puffs of albuterol during the case, you might get a respiratory treatment. So you order that stuff for PACU. We did not mention that you're also, part of your preparation is pre-op orders of anesthesia. Now that may have been done by somebody else a week before when they came into the pre-assessment testing area for anesthesia. That may have already been done, but whatever facility you're at, you have to find out if it's been done, because if it hasn't, that's going to delay your case. You don't want to do that. So I didn't mention part of your preparation is pre-anesthesia orders. Post-op orders you're going to write. You give report, find a way that works. In my facility now, that our anesthesia group was purchased by Sheridan, who has now merged with Envision. Man, it's a long thing. North Florida Anesthesia Consultants, and then Sheridan, and then Envision. I just say NEFAC, North Florida Anesthesia Consultants for short, because that's what we were when I started there. So that's how I differentiate us. But every place will have their own little protocol and how they do it. And on my ID badge, they made me wear this little thing that says, this is how you give report. Now, I promise you, I did not memorize that, and I don't have to do it in their order. you can teach old dog new tricks. However, I'm like, my trick's been working, so I'm not changing it. But you will probably want to have a guide to go by. I think there's one in the PowerPoint. You can use that one or a different one. And if you know that you've been using a certain protocol as an ICU nurse where you work, just use that, but add anesthesia places where parts that you think, so you know that you're using that routine. Main thing, when you give report, what's the first thing you're going to probably tell them? Name. Okay, so I'm going to say this, and sometimes I don't say their name, because again, everybody else is around it. Everybody there's taking care of patients. But so this is patient so-and-so, a patient of the surgeon, Dr. So-and-so, that we did a lat chole on what the procedure was. So they know that much. And then the RN is going to tell them stuff, how many drains they have, what the dressings are like, all that kind of stuff. Might say they have an IV in the right hand, 20 gauge. They had 500 of fluid. There was no Foley, so the urine was not measured. There was 5 cc's of blood loss. We did general anesthesia with an endotracheal tube. They were relaxed and reversed. I may have to say that. Or I might say they weren't relaxed. They know what that means. Well, if they ask you a question about it, then you need to explain it to them what it means. But that would be something too in emergence. We would have to, if we had given rocuronium and kept them muscle relaxed the whole case because it's a belly case, let's say we did a rocuronium, they need it relaxed so they can work in there. And afterwards, we're either going to give sugamidex or we're going to give a little Robenol and a little neostigmine to reverse the muscle relaxant we get. And you're going to learn about that monitor, trainer 4. You probably use it in ICU some places too. So you have to have a minimum of at least 1 twitch, and the literature is actually saying they prefer 3 or 4 twitches before you reverse them. But now with sugamidex, you just push that drug, and they're like really soon, within a minute or 2-ish, maybe 3, they go fully like they're awake. Wow, that stuff is like magic. In my place, we don't use it very often. It's more like a rescue thing if the other things we've done that are cheaper didn't work. So if you give muscle relaxant, sometimes the tincture of time, it's worn off and you won't have to reverse them. Some people you work with say, I don't care if you gave it 3 hours ago, you're going to reverse them. And they had a bad experience somewhere in their history and they're like, we're going to reverse everybody. Okay. Some people will say, no, it's been an hour and a half, you haven't given anything, so it's already worn off. It doesn't matter. You don't have to. So whoever you're working with, yes, sir. Yes, ma'am. That's how we'll do it. But you're the one that needs to ask that question. So go in with a plan, but know that you have options. Know that you have, if people, you might say, well, what would you like me to do? Say, my plan is this. Is there anything you'd like me to do differently? You're confident, and you may not have a complete plan because you may not know what it is yet, but you have a plan. Yes, you do. And they may disagree with it or tweak it or change it, and that's okay. They're ultimately responsible because you're under their ARP license. Even though you do have an RN license, and you're responsible for stuff too. However, you're in training, so aren't you lucky? All right, I think that's enough for that.
Yeah. You were saying for the PACU report that the RN, so at your facility, the RN goes with you to PACU?
Yes, and I don't know, I think it's like that most places. The OR RN goes with you, and then you give report. They'll give report, and I usually let them do their thing first, and then I fill the anesthesia detail. Because they'll tell them the patient history, I'll let them do part of my work. I'm sorry, it's true. See, the efficient work harder, smarter, right? You gotta work both. But yeah, so usually the OR nurse goes with you, and sometimes you steer put this into stretcher on steer. You steer it, and they just let you follow you or go ahead of you. I don't like it when they go ahead of me because I'm afraid I'm gonna, take them out from under. There goes another patient, and if I'm in an ortho room, I really watch out. But if I'm in another room, it doesn't matter so much. It's okay. But yeah, they'll go with you, and they'll give their report, and then I give my report. And then I always say, is there anything else I can do for you? Anything else you know before I leave? Now, I'm a customer service agent, right? I want everybody in my world that I can't control. I want to be there for them and be available. I want to be a good customer service representative. I don't want to just walk away and then they're going, look. I tell them the basic orders. If the patient's a little bit hypertensive, I'll say, well, this is what they were pre-op. So they were 150 over 80 pre-op. Now they're like 155 over 85. Okay, that's within 20% parameter. I'm not too worried about, but I just tell them this is what they were. And I did write clobetasol and hyperonium for you.
This is a little bit off topic, I
That's
guess,
okay.
about the extubations. So
Yep.
on the CRNA and SRNA Facebook page,
Yep.
I saw a poster write about how he had a veteran with PTSD, and he did a deep extubation to reduce the delirium.
Yep.
And he did it with the lights off, sitting up, and he said how he like threatened everybody's life if they talked or anything like that during the process. So I was gonna ask if you had experienced that with your military background, with veterans, and
Yes.
is that something that you kind of just learn as you go, or is there evidence? Because he didn't really say if there was like research about that.
I can honestly say that I don't know what the latest evidence is on it, but I can tell you based on experiential evidence that, yes, if it's quieter and kind of dark and calm, and everyone in the room is basically quiet, and then I'm whispering in the patient's ear as they're waking up, you're waking up on the surgery or whatever, and you just be as gentle and kind as you can, and they wake up, they tend to wake up more comfortable, and not swinging. Doesn't mean they won't do that. And it's great when I have patients that have that experience because they'll tell me ahead of time, listen, last time I went under anesthesia, I woke up swinging, so please forgive me now, or whatever. Okay, well, we're going to try to do this differently and gently. I just like to tell them the plan ahead of time. So they're already planting that in their head, right? This is how it's going to be. Okay, it's going to be peaceful, it's going to be comfortable, it's going to be safe and calm, and you're just going to wake up like you wake up in the morning from sleep. It's going to be perfect. So I plant that. Now, it may or may not be true. And I've seen that multiple times. But you have to control the room. You have to let them know. This person's got really bad post-traumatic stress, and here's what we're going to do. You know, and they want to comply, especially in the military facility, because they're like, yeah, I got it too. I wish somebody had done that for me. But I don't know the latest, evidence. Do you have a question?
Are the research of that? They say alcoholics also?
Yes, I would say, because generally it's really hard to dose folks, or even people like in chronic pain, so addictive personalities, or people that are in, so whether it's alcohol or whatever, people that are in chronic pain and then they become addicted to their pain medicine. So it's really hard to manage their pain. And the receptors are always at a constant level of, it's always there. And so it's really hard to manage it when they have extra pain, like the pain of surgery. But yes, they tend to wake up swinging as well. Yeah. You're going to see a lot of things, and you're going to eventually figure out what you could do differently to try to make it better. But I will say this, even though you've planned to do this kind, gentle wake up for someone that has post-traumatic stress or addictions or chronic pain, they still may wake up crazy, and that just happens. But you've done the best you can knowing that ahead of time, so you can try to develop a plan that will work. Sometimes it works, sometimes it doesn't. Which brings another point in this lecture. What are we going on? If we give, we're getting ready to start surgery, and they're induced, they have a tube in, the surgeon's getting ready to make surgical incision. What % of the people will react to that? Based on what you learned in your, 50% of the people respond, 50% of the people won't respond. What? What?
Is there a 1 MAC?
Yeah, there you go. You did read, maybe. So if they're a 1 MAC, right, 50% of the people will respond 51. Well, those aren't really good odds, because I don't want anyone jumping off the table when they get an incision. Do you? So that's why we have those other things in there. So you may have to go 130 MAC or 150 MAC so that person doesn't jump. Or another thing that works, muscle relaxant. Oh, yeah. If you're going to use it during that case. Just before incision, it might not be a bad time to give a bolus of narcotic and or a bolus of muscle relaxant, knowing that, like for example, rock, it might take a little while for it to get there. It might take 90 seconds to 2 minutes. So if you haven't planned that ahead of time, you're already off the table, and but I've already dosed it. Okay, well then they're going to be on the floor. Yes?
Now, what determines whether you're giving a muscle relaxant like intermittently versus putting them on an infusion?
I have not seen an infusion of muscle relaxant in the OR, ever.
Okay.
That's what you're used to when I see you,
Yeah.
which really makes your day and night better, right?
Definitely.
I'm just saying. I haven't forgotten those days either. Yeah, I know. In the OR, and maybe people do it. I won't say it doesn't happen. I haven't seen it happen.
Okay.
So you're gonna get boluses. And the reason, there could be a reason to keep it on an infusion, like if they, let's say they come to you on an infusion, they're intubated, they're gonna go back to ICU, they're intubated, you may do that.
Just keep it.
So it's possible, but usually we turn stuff off and then we control what we give as far as fentanyl, Versed, almost relax and all that. So I don't remember that I've seen that, but I won't say it's not possible. All right. In holding area, basically you just, what you want to do, you want to make sure everything is that patient is as optimized as possible for you. So you've already said hi, you've introduced yourself and your team, you're building rapport there. You're looking in the chart, you're looking to see if they have EKGs, if they have labs. You may want to do one of those, I think Dr. Pavlotti will do this for you, help you learn how to read EKGs better. Take that to heart. You only have to look at a few things, really. You know, a few little key things, you go, and then if they have an old one, you can compare it. Or what you can see on your, at least your EKG monitor, is it different? ST elevation, depression, all of the basics, okay? He will make you know more than the basics, but at least be able to look at one in a chart and have some kind of data that's going to help you do good safety anesthetic. As far as lab values, you probably know a lot of them because of, you know, your ICU experience, but if you don't, and you haven't memorized major parameters, do that. So you need to know them all, but make sure you know H&H, make sure you know glucose, make sure you know creatinine DUN values, potassium, sodium. Just make sure you have the ranges in your mind. So you know how they will write them on charts or they'll have them organized. Make sure that you can look at that. I like how it is now because it'll say L for O, H for high. Yeah, that helps me a lot. So then I'm like, you know, things I'll probably dump some of that, but don't dump it, memorize it, make sure you know. And then you can always look on the little, you know, you can hover over it and go, here's the range. You're like, oh, they're just like 1/10 of a point over or under. So it's not a big deal. But if they're way under, then you'll have that C for critical value. Make sure that you and the whole team are aware of those values, okay? That's something that's an expectation that you would already know. So in the holding area, this is great because you may, depending on where you practice, some people will put the IV in, sometimes you'll put the IV in. So one of the items you have to graduate is IVs. Like, I can do IVs. Or you might go, Robert, they didn't have to do very many. If you are rusty, make sure you knock those things out. Because we're going to talk about, for your clinical portion of this course, we'll talk about your Typhon record and how to enter that data. The Council on Accreditation of Nurse Anesthetists requires us to have OR hours, anesthesia hours, the types of cases, the ages, the ASA classifications. One of the things on there is IVs. People are like, I don't care about that. You better care about that because you have everything else met for the whole time you've been doing clinicals and you don't have enough IVs. You're going to stay an extra semester to do IVs. You don't want that to be the thing to hold you down. So I know you're going to be busy, but you're going to be well prepared. So you're going to have time to start an IV. And if someone's a difficult IV, that's when they're going to ask you to do it. And guess what? They already took every good possibility of a vein away from you. There's a big hematoma there, right? That's when you're going to get it. Oh, well, you're the expert. Just confidently, yes, I am. In the operating room, it's cool because if someone has a difficult IV start, you know the gas dilates blood vessels, so it's kind of like cheap. It makes it bigger and better, easier to monitor. Yes. And that's why people think anesthesia providers are real stars, right? It's not really that. Well, we are, but I just got to say it's because. All right, this is something I would learn. This is something I would learn, Ms. Maeve. Now, I did a quick one called SOAP. I may have put that in the notes.
Yeah.
Suction, oxygen, airway pharmacology. That's the one I do every day. I got, this is where I would start. And I recommend you guys doing this. But for me, I'm like, then I remember that's too big, too long. Too much to remember. So I made mine short for me. Machine check, they will be different at different places. Some of the machines do it themselves almost, but you still have to guide them. Suction, make sure it's there, it's put together, and it's functioning. Now, sometimes you'll have it all ready. You'll go pick up the patient and come back to the room and someone turn it off. Before you induce, test it, make sure it's on. Somebody, you have everything ready when you leave the room and you think it's ready, trust me. An anesthesia tech was being helpful, or an OR nurse was going, oh, let's not waste this, or whatever. Thank you. Just before induction, make sure your suction's working. This is wisdom from the wise. Because I was a student, had everything ready, went to get the patient, came back to the room, and guess what happened? Somebody turned the suction on. And usually, for most of the time when I induce and most of the time I intubate, most of the time I don't need it. But I tell you what, I tuck it right under the pillow, my right hand, right there, and it's on. This was a traumatic experience for me when I didn't have it on one day when I needed it. And there was something written on my email, and I don't know if it was the front and the back page or maybe an extra page, but make sure that doesn't happen to you. Make sure your suction's working before you induce. Monitors, make sure they're working. Sometimes you won't know. You're not going to waste equipment and hook up EKG to yourself to make sure it's working in the morning. Sometimes you have to replace a cable, or sometimes you have to get new dots. You laugh. But yes. Airway stuff, make sure you have it prepared and always be ready to intubate, even if it's a MAC case. You're planning on a MAC case, but you've got a tube ready, you've got an oral airway ready, you've got a MAC or Miller blade ready to go. You may have an LMA ready. And different places will tell you how to prepare, because some of them don't want to waste the materials. So they will say, nope, you can't do that. All right, that's okay if you can't do that. But you better be mentally prepared to do that. And realize in that case, that's not just in that case, you may have to intubate that patient. So if they let you prepare by getting the tube ready and the blade ready, all that, great. If they tell you not to because of cost, that's okay too. But know in your head that you may have to take it the distance. All right, make sure they have an IV. Make sure it's working in pre-op. And if it's not someone you're going to give Versed to, at least do a flush. Because there's nothing worse. Getting the patient off, well, there are many things that could be worse. But you get the patient already, they're on the operating room bed, and you're getting ready to induce, you go, oh, the IV is infiltrated. Okay. That's not a good time to find out. Now, there's never a good time to find out an IV's been infiltrated. I understand that. But if you knew ahead of time, you go ahead and do it in pre-op while you're still waiting for everybody else to do whatever, right? And make sure you know what drugs you're planning on, and sometimes that changes. Okay, again, with your CRNA, this is my plan. Is there anything you'd like me to change? Yes, no. They will let you know. They'll be very specific. Why would you do that? They may do that. Okay, just have a rationale for the thing you've done. They may disagree with you, but at least you've had a rationale. If you don't know why, like, I don't really know why, that doesn't bode well. They may go out of the room and figure it out. When you can figure it out, come back in. Okay. They might kick you out of the room. If you can't come up with it, there's a reason why you do everything, right? And if it's not based on safety or some kind of rationale, they might make you kick you out of the room and say, once you figure that out, go back in. You're like, what? I just got here. They don't even know my name. It'll be all right. Go find out what you need to do. Come back in. Well, this is why I did this. Okay. Again, they might disagree and go, well, that's a bunch of hogwash. Okay, so what? You had a reason. It's founded on safety. They may still have a better answer for you, but it's okay. Come up with something. You guys ready to take a quick break? I have a question first. Does everyone know where Gandhi is? I mean, not heaven. Yeah. So if you don't know where Gandhi is, because we know that's our rally point in case of an active shooter, we may change the plans. But if we have to evacuate this room, we're going to Gandhi. I just think that's a good plan. Even if you don't believe in Gandhi, it's okay.
Did you say that because you checked your email just now?
No, why?
There was a shooter on campus this morning.
What?
Come on.
Firearm discharged on campus, suspect arrested.
Oh, that's the part I want to know. You should have started there. It was just an example in class. So what I would have started, here's what I would say. Yeah. So did you realize that there was a person arrested today on campus because they had shot shots for fire? I'm in the Army. Like, oh, I PTSD.
In the doors, students got an altercation, and Reggie used it and told them to leave the room, and he fired it in the room.
Well, that's a good way to settle this.
Leave.
Yeah.
It's just a big
Wow. Oh, no, I didn't. The reason I said that is because
I don't think this ever happened here.
It wasn't that.
I was like, oh,
No,
no,
that's not like.
Where are we?
all I want to know, please. Oh, go your hand, please. I just want to make sure you know where our rally point is. If we ever have to evacuate this room because of some type of disaster, then Gandhi is just not this building, but one building, don't go through the bamboo, it's really appropriate. And then you'll see Gandhi just sitting there like, okay, at least if we go, we're gonna be in a good spiritual place, maybe, I don't know. All right, let's take a quick break. See you in 5, bathroom stretch. But memorize this, Ms. Maid. That will serve you well when you're thinking in your head, have you done all the things you need to do to be prepared for a case? All the equipment, and when I say equipment, that's everything. You go into a room and you have an IV bag. Where are you going to hang that IV bag? On a pole, right? And usually I put it on the side where the IV is, typically. Sometimes you go in, there's only one pole. Okay, we're going to hang it on that one pole. Are you going to move it to the right or the left? Think about this ahead of time. Not when you go in the room with the patient and go, nurse, could you give me an IV pole? Because I wasn't prepared this morning, I don't have one. You're not just going to lay it on the bed, right? You need somewhere to hang it. That's part of that, when you get the room ready, check those things. Make sure there's a bear hugger in the room. Make sure you have a hotline if you're going to use a hotline, and that's prepared, or an art line, and all the stuff that goes with the art line. That you're going to have all those things. Because we're expecting you, CRNA to SRNA, to have that stuff thought through and done. Especially if you called me the night before and said, here's our plan, we're going to have a hotline and an art line, so we're going to start a second IV, have that stuff ready. Sometimes people will do it pre-op, that's okay. We're going to do an art line, sometimes people do it pre-op, sometimes they wait till the patient's asleep. Be prepared. And then they'll go, yep, they listened to what I had to say. And there's prepared. You're still going to mess up, just know. Just know it. You're going to forget stuff. It's okay. I still forget stuff. I was working with a student yesterday, and at the end of the case, we do paper charting and computer stuff for the St. Vincent's. And so we finished out the record, and we were doing these eye cases. So they were pretty fast, not super fast turnover, but pretty fast. And she's totally self-sufficient, doing her thing. And, normally, there's 2 pieces of paper we have to turn in to our office, our little office in the anesthesia area for billing purposes. And I check that stuff, and I've worked with her several times before, and I checked the first couple of pages, the first couple of cases, and then I didn't check one, and then I was in the room, and I'm like, you know what, you forgot to put the procedure down. She's like, what? I go, yes, and you know what this means? In a month from now or 6 weeks from now, I'm going to get a note from medical records, and they're going to make me come between the hours of like 8 and 5. Well, I'm in the OR. I get there at 5:30, quarter to 6, and I may get out at 6. And I have maybe a 20-minute lunch, maybe. We don't get breaks in the morning after, so unless somebody's extra, which is we don't get breaks generally. So when am I going to get this done? I'm going to come in on my day off? No, because I'm here on my days off. My days off are great. I'm off on Monday and Friday there, right? Perfect. But those are like an awesome schedule. I do, because I get to be with you guys. But when am I going to go to St. Vincent's and medical records to fill that in? So normally, if that happens when I'm working with a student, I usually just go, I try to track down and PACU, but this patient was a, what we call fast track. So we're doing eyes, they didn't have to go to PACU, we bypassed it, they went down to the surgery center. I'm thinking, they're already home, man. Where am I going to get the record? So I said, you know what, I'm going to put you on a little field trip here. This is just to emphasize how important this is. So I said, and of course she doesn't know where those places are in the hospital, because she only knows how to go from her car to the OR to where we eat lunch in the closest restroom. That's what she knows, right? So I told her where to go, and she went off. I said, you need to go fill this record out. So 10 minutes later, she comes back. So I'm not going to get that notice from medical records. But no, you need to have every detail complete, because some of this stuff is going to come back to you. You will have to address it eventually. Why not just do it? All right, IV pulse. I cannot tell you. If you're going to do a case with, you're going to use muscle relaxant, you need a twitch monitor in there. Now, most rooms are already going to be stocked with it. Make sure it's there. Make sure it works. If they have batteries in there, just because you see it does not mean it's functional. It's your job to make sure before the day starts that that's done. You know BIS entropy, right? What is that? Do we know?
Bispectral index.
Bispectral index. Okay. What do we do? What does it do? It checks brainwaves. So like awareness, right? So you're going to learn, if you haven't already, you're going to learn this. I think Dr. Cavalani will learn that with you. There's a range when someone's awake, when someone's asleep, and everything in between. You will learn that. What is PPE? That's basic nursing. Standard precautions, remember that? Nursing 101. Personal protective equipment, whether it's a gown or gloves or mask. Yep. Eye protection. Oh yeah, that's important. It is. Emergency stuff, don't forget this, every room or every anesthesia cart will have a bougie. Is that boogie or bougie? I don't know. That's the B in ABCs. Boogie. Everyone know what this is, bougie?
Yes. Almost so.
It is a long, plasticky, rubbery thing. It's about this, maybe this long, and at the end it has a tip that goes up maybe a foot inch. And that would be something if someone has a challenging airway. I have a DL, direct laryngoscopy. Maybe I see a retinoids. I can put this bougie in. I put the tube. I thread the tube through it. So the tube's up here, the bougie. I'm putting it in the person's mouth. And then I put it in. I'm hoping. I can't quite see where the cords are. I'm doing the DL. I can't quite see it, but I'm putting this bougie in. Then I feel like ding, 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 the tracheal rings. I know I'm in the esophagus. That's the right one. I know I'm in the trachea because I felt the tracheal rings, right? Because the trachea sits anterior to the esophagus, which is posterior. If it's smooth when it goes in, guess where I am? Goose in the esophagus. If I feel the tracheal rings when it goes in, ding, 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 that's when you're hitting the ring. Then I know I'm in the trachea, then I can take the tube that's already threaded there and just...
Kind of like a guide wire.
It's like a guide wire or a style wire, sort of like that. Yep, that's what a bougie is. And most anesthesia carts have them somewhere close by. Just like they'll have an ambu bag, just like they'll have a flashlight, because if the power goes off, you're like, who cares? We have a generator. Okay, generators go out too. Ask the people in Texas. God bless them, and I hope all goes well for those that can recover quickly. Make sure the flashlight works. There is nothing darker than an OR. In the middle of a hospital, in the belly of a hospital, when the lights go out, the backup lights go out, I always check that even today. Now, has that ever happened to me? Lights have gone out and the auxiliary came on, yay. But what if I lost that too? It is dark. Oh, I've got a cell phone. That's going to last a little bit, but how long really will that work at 100%? It's going to go without even time. Can't plug it in and recharge it, right? Because the electricity's down. Yeah. So check your flashlight.
Does Dr. Pavlovi really wear a headlight? Just when he came up the other day, I'm like, oh, that's odd. Does he put it underneath his cap? Like, how does he wear it?
No, you have the cap, and then you have it on the outside. And yes. How often does he wear it? I don't know, because he's at UF Health and I'm at, but yes. He looks like he's ready to climb a mountain. And he's got his camelback on. He's got his gears ready. He's in the OR. Hey, Jonathan.
He wears the camelback in the OR.
Yes.
That's how you know you get breaks there because you drink a lot of water.
Yep.
I was like, you know better if you don't get a lot of breaks.
Yep.
You're
Well,
wearing camelback in the OR?
Probably not. Could I have been exaggerating a slight bit? Maybe. He does not wear his Indiana Jones hat in the OR, I know that. But he would if he could. So when you said odd, I was thinking that Dr. Pavlovi is one of the greatest characters you'll ever know. And he's an outdoorsman, and he's like an extreme sports kind of guy, and so is his girlfriend, who is CRNA I work with, who graduated from the program. And she's like when you see like the fitness guys, oh man,
Tires.
she does like the thing on the rope, and you see like she'll post a picture on Facebook, and she'll be the rope, and you're like, she's right near the top, and she's like, you just see the muscles. Wow. Awesome. Enough about Dr. Pavlovi. All right. I think in our discussion we pretty much talked about basic drugs to think about, but something I just thought of was if you go to extubate someone and they have a laryngospasm, a lot of times it might be because you didn't suction the airway first, because those secretions that are sitting there on the other side of the cords, once you take the tube out, guess where they go? Through the cords, and they tickle it, and then it clamps down. Laryngospasm. Who caused that? You didn't suction the airway. So I would say you did. How are we going to break it?
An algorithm.
There is an algorithm, but okay, what's the algorithm to break laryngospasm?
Positive pressure for a second.
Okay, positive pressure. So you know that APL valve? What does it stand for? A? Oh, so Dr. Pavlovi's already gotten to there from here. Okay, good. So the APL valve, you put a little pressure on there, probably not more than 20, and then you just hold pressure on the bag. And what that's doing is it's Well, it's doing a couple things. One of the things it's doing is popping on those alveoli that may have kind of collapsed during the case because you've been artificially ventilating the person. And it can actually break that laryngospasm, and just enough pressure to break it. If that doesn't work, what can we do? You can do a jaw thrust. Now just put your fingers right here, 2 fingers, and just kind of press forward. Is that comfortable? Does it hurt a little bit? Most people, it's a little uncomfortable. And that sometimes just doing like a jaw thrust like that, it can, and you're pushing the jaw forward, it can actually break a laryngospasm. Sometimes that works. Those are the more benign things you can do. So positive pressure, probably 20 water centimeters, probably. Maybe the jaw thrust, if that doesn't work. And then the drug we might give would be what? Succinylcholine. What dosage? Probably 10, 20 milligrams. And you will have to know milligram per kilogram or kilogram, mics per kilo. Those are the dosages. That's how you'll have to learn them. I'm giving you a practical dose, what I do. 10, 20 milligrams. Usually I don't have to do that. Usually if there's laryngospasm. First of all, they don't happen that often. I'm grateful. They happen more frequently earlier in my career. They don't happen as much now. But when they do happen, the first thing I'm probably going to do is positive pressure. And if that doesn't work, I'm going to hold it there, give it some time. And in the meantime, you're thinking, 1 second seems like 3 minutes. Trust me. Because you know where this can go if you can't break that laryngospasm. It goes down a dark hole that you don't want to be in. So then you might continue positive pressure, you might have someone else do a jaw thrust for you and see if that works. So, and then if that's not working, I give it and now I've learned to be patient in myself and realize that this has really only been 5 seconds, not 5 minutes. And then I'll go, okay, I'm not breaking it, it's not working, so I'm going to give sex. And the nice thing about sex too is it goes through 7 minutes usually. That's how you break laryngospasm. We talked about equipment. Oh, one thing we did not mention was a magnet. Why do we have a magnet in the room? Someone has, pacer, AICD. A lot of times with pacers, they won't use it. With an AICD, they will. And it depends on the type. Is it a St. Jude? Is it a Medtronic? Some of them have to be interrogated before and after. St. Jude's do, so you have to call a rep, and all that has to be organized ahead of time. You don't usually do it, but you ask the question. Usually the orators would have that all for you. If it's a Medtronic, you can put it on, and it'll go, I think that's the right pitch. But usually you don't have to have a stethoscope to hear it, but it wouldn't be a bad idea to have your stethoscope just in case, but usually you can hear it, especially if you're listening for it. Then I usually tag a dermot in place once I've heard the tone, and then you chart that you did that. And that's so that when they're using the Bovie, that your heart doesn't think you're in VTAC. We don't want that to happen. So when they're finished with the case, you take it back off with the Medtronic, and it goes. It tells you that it's back functional. But other ones you'll have to get interrogated, so it just depends. But just know that you'll have to, I always check, that's part of my check in the day, where's a magnet? Because I may or may not have someone with a pacemaker or an AICD all day long. But if I need it and I didn't check for it in the morning, call the tech. Hey, I'm in this case, would you mind bringing one in? I have everything prepared. So have that. Have your Twitch monitor, turn it on to make sure it's working. All right. In some cases, you're going to need this. It's not usually in every single room, but if you have someone that's diabetic, you need to know what the protocol is. When are they going to do it? Usually they do a AccuCheck in pre-op, or when they first come in the surgery center, they'll check it, and then usually in PACU, they'll check it. So you may not even do it. If there's a hemostat or an iStat, sometimes, my badge won't let me, I don't even have access. They don't even train us to use those, which is crazy. When I was in ICU nurse, I did these. I'm kind of not grown up enough to use now. So we have other people do these for us, but rarely, only if someone's not managed well do we have to do checks during the case and if it's going to go on the case. But just know that if you're going to need that, you'll have it. Same thing if you're going to do an epidural or a spinal, have that stuff in the room. Have the glove size, the sterile glove size that you need, and also that your supervisor might need. I'm not saying you're going to have to jump in and help you out, or your CRNA. They may have to help you out when you first start. We all have to learn. It's okay. All right. When you are finished with your case, you want to go into the case knowing what the plan is. Are we going to go to PACU? Where are we going? Are we going to the ICU? And what do? We give report, just the OR nurse gives report to the ICU nurse. Do they transport? Do we transport? Where are the monitors? I'm going to go up to ICU. I'm going to transport them on monitors. What monitors do I want? What is required to do that? Start with the end in mind so that you know. And sometimes in a case, you plan to go to PACU and extubate the patient, that whole thing. Sometimes you don't. Sometimes you have to go to ICU. Depends on how they do. Pre-induction. I think we've covered most of this. One of the first things I have to do that I didn't mention when I introduced my patient is you have to ID the patient. You have to have two. So we do their name and their birthday. And you'll find the protocol wherever you are practicing how they do it. But they want you to identify the patient. Every single person that has contact with the patient, I want you. So they usually have an ID band. And usually it's name and birthday. Make sure you know that. Then in the pre-op area, you're going to do your assessment. Wow. The main assessment you want to do, heart, lung, and airway. You want to look at the chart, look at the labs, look at the EKGs, look at the respiratory report. They have an X-ray, chest X-ray. But you need to do an airway exam because you're going to be the one intubating that patient. You need to do heart and lung exam. Even if it's a MAC case, you still have to do the full thing. You still have to prepare the same way. Oh, this is a point I didn't make earlier. When we are going to pre-oxygenate the patient, we get them in the room, we have them on the monitors, we're getting ready to induce, you must pre-oxygenate. But really a better technical term would be denitrogenate, right? Because our air is 70% or so nitrogen, 20 some, 90, whatever percent. Oxygen, 21%, we'll say. Unless we have them on our 200%, so that changes. But we are really trying to get rid of the nitrogen in the lungs and replace that with oxygen. That's what we want to do. That way they'll have more reserve in there if we have a hard time intubating. So they have more residual oxygen than normal. Because normally, again, 21%. What we're breathing right now, 21% is in there. So we want to get rid of the nitrogen, replace it with oxygen. That's why you put the mask on and have them breathe. Different techniques for that. Some people say take 3 or 4 deep breaths. Some people use a time thing. So we're gonna do this for 3 to 5 minutes. That's a long time in your life. Let everyone in the room wait for you to induce. Whatever technique, you are denitrogenating, getting rid of the nitrogen. Before you induce, you must have a set of baseline vitals as well. Do not push those drugs for induction until you've got a set of baseline. That's also, what if the pulse ox isn't working? You got to troubleshoot that before you induce. What if the EKG is not working? You got to troubleshoot that. All that stuff needs to be functional before you give the drugs where they go to sleep. We already know what the meds are, but something I didn't mention, but we want to blunt the sympathetic response to the direct laryngoscopy. That cold metal blade sticking in someone's mouth, whether you're lifting the epiglottis or you're going in the vallecula, that causes a person's heart rate and blood pressure to go up. If you don't believe me, try it at the next party. Just kidding. So we want to blunt this sympathetic response, and by that I mean heart rate and blood pressure shooting up out of the sky. That's what happens. That's the sympathetic response. Your body does not like that. So to do that, to decrease it, what drugs are we going to give? We already mentioned one when we talked about the sequence. Lidocaine would be one, and that also helps with the propofol. So that's the reason we said earlier, the lidocaine helps decrease the discomfort of propofol for folks. But it also helps decrease the sympathetic response your body is about to have to the DL, or even placement of the LMA. That's not a natural thing to go in there either. What other drug? Fentanyl, typically. I like fentanyl because it's quick. You can see them go from breathing to not breathing if you give too much. And it goes way quickly. So one that would burn a bridge would be Dilaudid, if you use Dilaudid, which is a great drug, don't get me wrong. I think it really manages pain well. But to blunt the sympathetic response to DL, we would say lidocaine, how much? There is a milligram per kilogram. I usually give 50 to 100 milligrams of lidocaine. How much fentanyl? Usually 50 to 100 mics. That's to decrease the sympathetic response of you putting in a cold blade to intubate. One of the things that's going to be the coolest, best thing you're going to learn to be a good anesthesia provider is how to mask. You think you're good at it now,
Sorry?
well, you may not. You may know you're not.
Really?
They have a standard size mask, unless we're working with pediatric patients, then you get the leaf, they're so cute. But for adults, they just give one size. And you have a person with a little tiny petite face, and the mask goes like from here to here, right? You're like, so you don't get a good seal. I mean, it's crazy. Then you could find a pediatric size that would work. So if you're ever assessing your patient in pre-op and you see that they're particularly petite, you could probably find a pediatric mask that would work. So think about that. But then you gotta know where the pediatric cart or the pediatric supplies are in the anesthesia workroom. That's another thing you have to learn. But you have to learn that anyway, so you might as well do it. What if their face is humongous and the mask goes here? That, trust me, it's happened. So you have to adjust based on what you find, and you have the equipment that you have. Just think about those considerations. Learning to mask, yes.
Sorry, you might be about to say it, but in the book, I think it said something about typical masking, people that are difficult to mask, you know, the beards and those type of things. But one of the things that caught my eye was a BMI of greater than 26.
It depends on where that BMI settles. 26 ain't low to me too, I just gotta tell you. So does old people being older than 60, but I'm just saying. So, yeah, so things that make it difficult to mask a person. Someone that has a full beard, or even a partial, like, whatever they call them. I don't know much about it. Yeah, thank you. That's right, you guys know. So because of the hair, it makes it hard to get a good seal. If you just have skin to skin, you can usually get a good seal. So masking a person, if someone's BMI, usually I put it a little higher than that, but I will not disagree with you anyway, right? I mean, so forget it. But if someone's BMI is here, like me, that's different than someone's BMI that's here, or someone's BMI that's here. So if it's here, you're thinking difficult mask. They may or may not be a difficult airway, but I'm going to use a ramp, I'm going to use a glide scope, I'm going to call another provider in, I'm going to go, all right, we're getting ready to go to sleep in this room. I'm going to wait till you get here before I push the propofol. I already have them ramped up, their shoulders in good position, I already have a glide scope ready. I'm ready, but I want another pair of trained anesthesia hands to help me. Now, I don't care if it's a CRNA colleague, but in my practice, it's going to be an ologist. So, and even still, sometimes, someone that just has a BMI here, I want my ologist there because I'm going to hold the mask, jump throws, good mask, while they do the back. Now, if I'm in the Army and I'm by myself, I get one of my nurses around or one of my techs or whatever, and they do it. And they're like, oh, no. Yeah. I'm like, yeah, you did. Thank you so much because I couldn't have done it without you. Awesome. You brought it. So it just depends on the person, but learning to mask. What am I, okay, I turn the APL valve a little bit, maybe 10 to 20 centimeters of water. And I'm squeezing the bag, I'm holding the mask, I've got, well, it's working great. What am I looking for? I'm looking at the patient.
Chest rise.
Chest rise. And what else am I looking for?
Saturation.
Frog in the mask, compensation. If I'm concerned that I'm getting a lot of air going through the sphincter and going through the esophagus into the tummy, I'm probably not going to see the tummy start getting swollen unless I'm really like you're doing like that could happen. You could do that. And then they throw up on you. You probably won't do that again. One of those nursing things you learn, right? But if I'm concerned that like they have a little bit of chest rise but not a lot, I might have someone to put a stethoscope and listen over the tummy. Do you hear it, bubbling in the tummy? I might have them do that. Get as much help as you can, but one of the first finesse things you're going to learn, even besides intubation, learning to mask well. You want good oh man, I almost came out of the pen. Good gas exchange. Anything with an AS in it, I'm having trouble with. Put the G, okay, gas. All right. Learn how to measure these, and how to put them in. That's probably nursing, again, I don't know if it's 101 or maybe EMT 101, but you need to know how to measure an oral airway and a nasal airway, know the parts that what they're called, and be able to do that. So look that up if you don't know it. That'll be part of your basic airway management lecture. Sometimes we mask without an airway. Sometimes we slip an oral airway or a nasal trumpet in. Remember when you put a nasal trumpet in, even though it's curved, it doesn't go in, it's not curved. You're not putting it, it's straight in here. These turbinates are straight. If you try to curve it, you're not really doing yourself any favors other than causing more mucus blood and all that stuff. So, yeah, it curves at the very back, at the very end. And you put it straight in, and then you gently, this is after you lubricate it, I'm assuming that you're thinking about it. Okay. So you lubricate it, you put it in, you put it straight in, and then when it gets close to that curve, you may have to turn it a little bit so it'll go around the corner. LMA induction. Do we use succinylcholine?
No.
Are they going to be on a ventilator? Maybe. We can use pressure support with an LMA, as long as it'll lower centimeters of water. Yes, you can. But usually, they're going to be breathing spontaneously. Just think, if you're using an LMA, the patient has to breathe spontaneously. Is an LMA a secure airway?
No.
No, it is not. What's a soft bite block?
Something you make.
It is something you make. You take 4x4 gauze and you roll them up and put tape around them. You can put one here, just one back in the molars, so they don't mash the LMA where they can't exchange air. Sometimes people put one on each side. That's what a bite block is, a soft bite block. They actually make them. They actually a little cotton that's already been made. It's about that big, maybe that big around that you put in. But you might be the one that has to make it. Intubating drugs, we talked about that for induction, and then when we intubate, we're going to use Sux or Rock or Vecuronium. Just take Vecuronium off that list, or Mifepron, or all those things. You'll talk about those more in pharmacy. But for today, intubating drugs. What's NDNMB? Non-depolarizer. What are two drugs that go in there? What's a depolarizer? Are you sure? Make sure you can explain the difference. That way you'll be prepared for pharmacology, okay? What they do and how they're different. You're also going to have to, once you intubate, secure that tube. Don't just let it flap in the wind. Depending on the kind of surgery you're doing, if they're going to do a right carotid, you don't want the tube taped to the right, which is your natural place you're going to tape it most of the time. You're going to have to move it over to the left. Tape it to the left. Sometimes they want it midline. Like we use a NIM tube, they're going to do a thyroidectomy. They have a tube that's got wires that can actually check the airway nerves while they're doing the surgery. It goes, and then they go, oh, got close, okay, back off. They would be a midline tape. Know where you're going to go. Something I didn't mention in induction, you know, you do that little lid reflex to see if they're asleep. Then when they don't have a response, tape the eyes. Because one of the main things that happens to people in terms of anesthesia claims for morbidity and mortality is corneal abrasions. And you might be the one that did that. Make sure your ID is not rubbing on them. Make sure your stethoscope at the end around your neck is not hitting them in the face. You don't think about those things first because you're like so focused on the task, right? Think about those things. You don't want to cause that. So right after you do the lid reflex, my recommendation is tape the eyes. Now, other people will have a different routine when you're working with them. Yes, sir. Yes, ma'am. That's how you do it. As long as you tape the eyes, that's the main point. Oh, yeah. Remember this? Don't forget to turn on the gas. And in the meantime, while you're running around like a crazy person when you're starting, when you induce them, their blood pressure is going to tank. You've given 100 of fentanyl, you've given 150 or 200 milligrams of propofol. They're dilating. And guess what happens to the pressure? So while you're running around making sure everything's neat and clean and well prepared, don't forget to look at the monitor. It's your job to keep them stable and safe. I like this. Look, listen, anticipate. Somehow with a sense of calm inside you. At first, it's not really like that. And when you do your observations this semester, you'll be like, how in the world do they keep track of all that stuff? You will. There'll be a checklist, there'll be a routine, there'll be things you will learn, and that's just, that'll be your go-to place, and you'll be able to do it. You do this 5-minute check. This is Dr. Welliver. I don't think you've had him for any lectures yet. He's awesome. And he was my favorite instructor when I was in school at FIU. He lives up here now. 5-minute checks. So let's say you're in maintenance now. I'm going to give you, everything's together and everything's gone well. And you're in maintenance phase, and so every 5 minutes, you're like, start where the IV, let's say the IV's on the left side, you start with the left, is the IV dripping? Yep, okay. And then you go, okay, here's the patient's bear hugger's on, and the bear hugger's turned on, and it's up. The tube is in the right place, everything looks good. You're looking, okay, this is okay, yep, their head is in their good position, it doesn't look like it's in some crazy little thing. Everything still looks caged, secure, their eyes are shaped. Okay, I'm going over here, here's the monitors, I'm looking at the heart rate, looking at the blood pressure, I'm looking at the end-tidal CO2, the O2. Okay, I'm looking at the monitor, I'm looking at, excuse me, the anesthesia gas machine, everything's balanced. Okay. So you do that 5-minute check. If there's nothing to do, there's something to do. If you were sitting there going, I got this, don't do that. Do not do that. I would dare say don't even sit down for the first year. If your CRNA insists that you sit down, sit down. Otherwise, I would not. Now, if you're in a 15-hour case, okay, I give you that. But don't sit down for the first, I don't know, 3, 4, 5, 6 hours. It gives the impression that you're not being vigilant and you're not paying attention. Now, you may be able to pay attention, you may be vigilant. My recommendation, and this is not an order, this is just a recommendation to help your first times in the OR go smoothly. Don't sit down.
Okay.
I'm just saying. Now, you won't see me till a year later, so I'll say, have a seat. But I'll expect you to get your own chair. Because that one there, that's my little throne. I mean, that's where I sit when I'm working with a student. So, just for the record, you can make a note of that too. All right. Look, listen, anticipate. Half of what we do is being vigilant and anticipating what's going on. Right before incision, do I need to redose them with narcotic? Do I need to give some muscle relaxants? What do I need to do? Because I don't want them jumping up because I base my anesthetic on, and this is crazy, 50% of the people will not respond at this MAC to surgical stimulation, but guess what? 50 will. So I'm going to overdose them, so to speak. Going to give them more than they need to overcome that surgical stimulation initially. And then I'm going to back down. I'm going to keep them stable. When I say stable, heart rate, blood pressure, breathing, end-tidal CO2, O2. You're going to learn all the tricks of the trade. It's going to be so awesome. You guys are going to love it. This is the greatest job in the whole wide world. Yep. And when you feel insecure when you're observing, that's okay. It's normal. You will get there. At first, it's going to be like, oh boy, how am I going to keep track of this? You will. You will. Baby steps. And all you can do is the best you can do where you're at. Our program is set up so that you get to the OR as quickly as we can get you there. Some programs wait till you've been in class for a year and a half or a year to a year and a half before you even go to the OR ever. Well, those people, man, they can whip out the answers. They're about ready for the boards, basically. But they don't have that clinical experience. So when you get pimped, when you have CRNAs that ask you questions in the OR, they can just rattle out. But when you ask them some kind of practical thing, they may or may not be able to help you out because they don't have the experience. You guys are going to feel knowledge-based deficient, probably. We haven't talked about that in class yet. That's okay. That's not really a good answer. You know, you have to say, I'm not sure, but I need to study that, or I can get back to you, or whatever. Fake it till you make it. Be honest. Don't try. If you start going down the path where you pretend like you know and you don't, that is not a good road. Better just to say, I don't know, and don't offer to go look it up. If they tell you to look it up, you do, and then you report back to them. This is another tip. You know, you feel guilty because you didn't know, right? So you go, I'll be willing to tell you. I don't know. Okay. Now they'll say, well, leave the room, find out, come back. Or they might say, well, tomorrow when you come, I want you to give me this full report. Trust me, they probably won't even remember. But if they don't let them look for you. You go, you say, hey, I have this. I looked this up yesterday, and did you want to talk about it? And they go, no, that's okay. We're living our lives. We're doing our thing, right? But if someone gives you an assignment, you do it, and you report back to them. But don't offer to do it. Let them, I'm just telling you. You're going to look it up anyway, trust me, right? You want to know, because you go, I didn't know that. I feel like I should have. Even if you haven't read about it, even if you haven't had a lecture on it, I want to know that. And you do. You want to know that. So you're going to look it up anyway, but some people may ask you to be accountable for that. Look, listen, anticipate. We know what to do for maintenance. Oh, yeah. That's what we're using trainer for. We cannot reverse the patient until they have how many twitches? 3. At least.
1.
At least 1, but it's preferred to have 3 or 4. And I have to say it that way, because we always would say 1. So I'm not sure how it is on the boards. If one's the right answer, so one might still be the right answer. A minimum of 1, but we prefer 3 or 4. Another hint, make sure you know how to work that operating room bed. Now, I call it a bed instead of a table because when I'm working with patients, I don't ever want to say, go to the table. That just doesn't sound right. It's like a science experiment, right? You know? Now it is. Why is this so narrow? So the surgeon can reach you. Oh, that makes sense. So don't turn over or anything because we got to strap down. Stay right there. I call it a bed instead of a table so that it just seems more humane. You're going to put me on a table. I'm like, is this the autopsy? I don't know. I want to be put on a bed where it seems warm and toasty and comfy. To me, my bed's my place to go because I'm like, great day, thanks for another good day, God, and now I get to go to sleep, and that's awesome because I'm getting rested and refreshed and probably have great dreams at home. Here's an important slide, probably one of the most important. Look, listen, anticipate. You are also responsible, not just hemodynamics, but you're also responsible for trying to figure out how much blood loss there is. There are lots of different ways to do this. We are going to give you a way to calculate it so you have something to start with, but know that it's not a good science, meaning that it's not exact. And it's really difficult to determine how much blood loss is. They've done studies where they had like 10 cc's, 5 cc's, 20 cc's, and they put them on these little like pads, and they had people guess how much there was. Rarely did people get it right. If they did, they were lucky. So you have those, so you have sponges and you have gauze that you're going to be figuring out how much blood there is. You have canisters you're going to be figuring out. They have these things called Neptunes. They keep it for every single patient, and there's like, 50 gallons in there, and you're like, they reset it for each case. But how much irrigation have they used? You might go, wow, that's a 1,200. No, it's not 1,200 blood loss. It's probably just 200 cc's, but they did a liter of flushing irrigation. You will need to develop a system of checks and routines, and that's really what this lecture is about. Stages. Where do we want them for surgery? We want them in the operative stage. Somebody said for stage 4, the danger zone, and went to that old movie, what was it?
Top Gun.
Yeah, Top Gun, thank you so much. The danger, that song always goes through my mind. Well, this is not a good place for patients to be. They've gone over that edge of viability in life. Don't let you be the one that did that. So if we're going to extubate someone deeply, which again you probably won't do for another year or so, which of these stages will we do it in? 3 or, yeah, 3. Or if we're going to extubate someone and wait, it'd be 1, right? But we want to stay away from this one, the excitement of area. This is what happens in the different stages, so I'd be familiar with those. The first stage, they're not going to remember stuff usually. Second stage, there may be some movement, there may be some eyes moving. They may not be equal, they're likely to have a laryngospasm. The third stage is where we want them, and this is where we talked about some of the different MAC areas. When we are going to get ready for surgical stimulation, you may have to increase this. It's endotracheal intubation. This is where you might have to increase it. This is that adrenergic response, sympathetic response. So you might have to increase it initially, but you better remember to turn it down, or what they might end up to that other stage of anesthesia. You don't want that, right? You don't want that to happen. These are different planes in stage 3. Where we lose those blink or eyelid reflexes in 2. And it tells you what's happening physiologically at each of these. When they're going to need to be ventilated and need your assistance is in plane 4. Their diaphragm's not doing what it's supposed to do. Well, it is because of the drugs you've given them. But yeah, you're going to have to intubate them in terms of they have to be intubated, you have to put them on the ventilator. Be aware of these. We want to stay away from this. Anything that says cardiopulmonary failure or death, yeah, that's not a good thing. Here's what happens pupil-wise. And in stage 2, sometimes you'll have a pupil like this, and sometimes you'll have a pupil like this. They may be different. We talked about deep extubation. Let me make sure I'm not missing anything. Oh, something that we say, how people go to sleep when you do induction is a lot of times how they wake up. So if they go to sleep like crazy and wild, a lot of times just expect they're going to wake up that way. Okay? It's not always true, but we generally say how they go to sleep is how they wake up. They go to sleep peaceful and everything's great. They wake up peaceful. I use my massage therapy techniques with them, though I'm no longer a licensed massage therapist. I got rid of my table, so don't even ask. But so I whisper in their ear, even if the room's crazy and they have music on or whatever they're doing. Some people actually have them turn that off, make everybody quiet. I just have them focus on that one. You're getting ready to go to sleep. We're all here to take care of you. I'm getting ready to give you that sleepy medicine. I give it. Your eyes look like you're getting kind of tired. We're all here to watch over you. You're going to get some great rest. We'll see you when you wake up. And I do the lid reflex, and you're asleep. But you know what? The hearing is still there. Note this. The hearing is still there. So if you go, this big old fat person, 3 times in a row, you know, or you say, oh, did you see that wife or that husband, man, they look like they're 100 years old, or whatever, they can hear you. So that's when I say, hey, lid reflex, tape their eyes, I go, sweet dreams, have a good rest. That's what I think, that's what I want them to hear. Now, do I always do that? Usually. Do I always do that? Mostly. Have I ever said something inappropriate? Yes. And I ask for forgiveness. And when I catch myself doing it, I stop and I say, you know, let's get back on track. If this were my mom, my dad, my brother, my sister, the person I love, I wouldn't want anyone talking that way. And we get caught up in the job sometimes, and you know, you've done it as a nurse, right? Just remember, everyone deserves our dignity and respect. Whether they're awake or not, it's still our job to treat them that way. All right. PACU orders, yes, yes, yes. What's a T-piece?
It's for a trach.
That's it.
Oh.
Trach thing?
So if someone is still intubated, or someone has a trach, and you need to give them supplemental oxygen while you transport them to PACU or ICU, you can use a T-piece. It's hooked up to O2, and if they're breathing spontaneously, you may not have to do anything. You may have to hook it up to an bamboo bag and supplement them. Report, we already talked about this. This is just one way to do it. Whatever it is that works for you, you just have to include all the components you can think of in a concise manner. And before you leave again that bedside from the PACU nurse, always ask if there's anything else they need to ask you or anything else you can do. Another way you'll win points is when you drop off your patient, you help hook them up. The blood pressure cuff, EKG, put the pulse ox on, those kinds of things really help them. And they'll go, oh, this person's going to be good. Fake it till you make it. Report, PACU orders, we've done. We will stop here. Are there any questions on the second batch of slides? It's really kind of more details on the same stuff. But if you have a specific question, I'll be glad to address that with you. Did you like the quiz today? Yes. I'm so glad to hear that. Yes.
I just was curious about your experience with angioedema, and if you have a tongue that's swelling and you have to do it quickly, and just some tips, I guess.
Well, I've had small episodes of that through the years, but I've never had like a full-blown, their tongue was like within, a few seconds, their tongue was protruding out and there was no air. I haven't had that experience, so I can't really speak to that specifically, but whenever I suspect it, what can I do? Get the tube in as quickly as possible. That's the only thing I'm thinking about. Just get the tube in place. That's what I'm thinking. Usually it happens early as opposed to later. So I'm not usually thinking that in the maintenance portion or the extubation portion, the emergence part. It usually happens earlier on if it's going to happen. Now I'm not going to say it won't or it can't, but usually it's something that happens earlier when you push the drug that have this anaphylactic reaction to it. All I'm thinking about is nothing else matters but me getting the tube in the right hole the first time. That's what matters. Because after that, they were going to have a cry for a trach or something. an emergency area. So that's what I'm thinking. But I already have somebody calling for help. Questions? Complaints? Let's go to Ms. Carroll. Yes.
I guess on that, just a curious question, how many MH cases have you experienced?
I have never had an MH episode happen in the OR. I've taken care of MH susceptible patients or people that didn't know if they were or not, but family members were. So I just had everything ready. I treated it like they were MH susceptible and have not ever had that happen. And I hope I never do. Depending on where you live in the United States, there are pockets of MH places because people tend to stay close to home when they grow up and have their own families. There are places where it happens way more commonly. But I have never had to do that. Has your sister ever had to do that?
No, I don't
Yeah.
think so.
Yeah, you would hear about it, I'm sure.
Yeah.
The good news is it's super rare. The bad news is what we have done caused it. Because we're the one that pushed the sucks, or we're the one that turned on the bottle anesthetic agent. And those are the triggers. Now, MH, we think, can also be caused by exercise-induced. It's something related to that. And there's other conditions that are similar to MH. But as far as a MH thing happening in the ER, I have not seen it. But one of the things you need to do, you probably got this on your scavenger hunt, is where's the MH card, the machine, whatever facility you go to, find out where that stuff is, because you need to know where the dantrolene is. That's, of all the things, the dantrolene is the stuff you need. I think I put the dosage on there. What's the dosage of dantrolene? Milligram per kilogram. I'm looking for a number. I'm sure you memorized it for the quiz today, right? And it was just 1 or 2 slides on MH. We're going to talk about it tomorrow.
2.5.
Yeah. Okay. So let's put that to memory. How much dantrolene do you need to give when you suspect a person is in an MH crisis in the OR? 2.5 milligrams per kilogram. So if you're doing your observations and that's something you suspect, then you already know the dosage, right? You got that in the bank. You won't forget it. What is it?
2.5.
If someone is having a laryngospasm, what's the first thing we're going to try to do to break it? If that doesn't work, how much sucks?
10 to 20.
Okay, so I got you out of a couple crises already today. Make sure you know where Gandhi is. Make sure he's not harmed. And I'll see you guys next week. Oh, next week we have Diana Halfway is going to be here. I had not planned to be here because ANA is that week, but my spouse was so awesome. I think they're doing like a red, like it's really later in the day. So I get to be in class. I get to come to class, and so I'm so glad. So I can introduce you to Diana. She's awesome. And so you're going to talk about regional anesthesia, maybe a quiz, especially since I'm going to be here. So maybe another quiz, maybe a different kind of quiz. But yeah, you'll really enjoy her. And she's the clinical coordinator. I think she shares that responsibility now with maybe Jake Atkins at Halifax. So I'm glad you get to meet her. So you see a person. So when you go to a clinical site for the first time, you go, oh, I know her. Yeah, I'm familiar with things. Questions?
I just have an announcement. If y'all don't care to stick around for a minute, we can chat about t-shirts. If you don't care, you can. But
now, do you have another
time? Stick around.
Stick around. Now, do you have class after this? No. Okay, so for those people that we're going to meet, maybe with Ms. Carol and myself, I'll go up and see if she's there. And yeah. Do you guys know where my office is?
Is it in the new building behind?
It is in the new building. It's in building 4. So people that were thinking about maybe meeting with me, building 4, 2nd floor, I'm in 2402, and she's right next door. So if one of you or all of you want to stop by, at least you can see where our offices are. And if she's there, we'll meet or see when she's available. And if not, then we'll just do it via email for a day next week or something, okay? Okay, fair enough. Is this on?
Yeah, because we got doubled up yesterday.
Yeah.
Thanks for that.
Sometimes